There is another video. So welcome to Buenos Aires. It's really a privilege for us to have you. This is, I guess that they are moving. Okay. There is, well, this is my agenda. This, first of all, a global introduction to the epidemiological situation of renal cancer. This is the cancer burden along the globe. Most of the tumors are located in Asia. Look at Americas. Americas has the 21%. This is the data from 2020. Kidney cancer is in the 16th position of all the tumors around the globe. Let's see the regional cancer distribution in Latin America. Look at the red bars that are Brazil, Argentina, Mexico, and Colombia. You have the huge numbers in cancer regarding the population of each country. These are the first four most populated and with more cancer around Latin America. This is, as you know, this is the epidemiological signature that was published in New England Journal of Medicine 4 years ago, where the incidence of renal cancer is growing and mortality is still at a plateau. This is our national incidence of all cancer. Look at, we have in Argentina 15 cases per hour. Renal cancer is the number 5 in terms of the top 5 renal tumors. Here is the table. Look at breast cancer, colon cancer, lung cancer, prostate cancer is 5,000, almost 5,000 new patients per year. So we have 14 new renal cancer patients per day. This is not very pedagogic, but let me see how many new cancer patients you have in the region. 35,000 new patients per year. So it's a very huge number. Look at the four ones: Brazil, Argentina, Colombia, Mexico are the most common tumor. But if you see the incidence as well as you see from Uruguay, that in the next couple of slides you are going to see, Uruguay have a lot of number of renal cancer patients. Look at the numbers here. This is the ranking where renal cancer is. Look at in Latin America, probably the south of the continent has more cancer of the kidney than the others. This is Argentina, and if you consider that 20% of the patients they have a metastasis at the very beginning, for us, there are 1,000 new patients with metastasis at the very beginning. In the whole globe, it's 87,000. So you know that there are a lot of histology. It's not one histology, clear cell is the most common cancer or renal tumor, but you have a lot of histology, so pathology must be trained. So we need referral centers in our country. We have some very good pathology along the country. Argentina is a very long and huge country with several populations, with a lot of inequities and disparities, but pathology is the most important thing to perform diagnosis. So our standard approach is to treat advanced renal cancer. You know that surgery, chemotherapy is not useful in this type of tumors, and radiation therapy. Multidisciplinary tumor approach is the only way to treat patients. That's in Argentina, that's in the US States, that's in Korea. So for us, the multidisciplinary team is the most important issue. We know that in local therapies, there are more precision with new radiation and new sort of surgeries. I have been treating patients with kidney cancer since 1994. So at the very beginning, we tried this, the tumor cell, the cell kinetics, and the cell cycle. So chemotherapy is the only way to treat patients with cancer. This is the menu of the medical oncology in 1990s. Look at, there are no immunotherapy and there is no chemotherapy, there is no target therapies. That is the menu. That's not only for renal cancer, it's for all type of tumors. And then after 2019, this is the menu. So this rising, there is growing a lot of new drugs that are developed. So the field in the research and the field in treatment is really growing a lot. I love chess, so this is the chess to play in renal cancer between 1960 to 2005. So look at interferon, interleukin-2, and surgery are the only three options that we have in the field. After this knowledge with angiogenesis, with VEGF receptors, and new drugs that have this target, this chess play change. So one of you know that when von Hippel-Lindau gene is mutated, you have a lot of accumulation of HIF, and HIF produce an internal in the nucleus, and they promote a lot of transcriptional factors. So the angiogenesis is the main issue in renal cancer. That allows to develop new drugs that were the inhibition antagonist or inhibition of this sort of pathway of VEGF, trying to inhibit the proliferation and migration. The first drug was sorafenib, sunitinib, and then pazopanib were the main drugs that are in this field. So from until 2018, we have sunitinib, pazopanib, interferon plus bevacizumab, and observation or surveillance. That are the options in the treatment in Argentina and in the rest of the world. Axitinib and everolimus appears in that way. And the other main issue in medical oncology from 2015 to now is the appearance of the immunotherapy. This is a cytotoxic T cells that is killing a cancer cell. If you know this graphic is kidney cancer has the most microenvironment rich in lymphocytes in T cells. So T cells are the most rich in kidney cancer. So we have two Nobel Prizes. They are not from Argentina. We have Messi and Maradona, but this is not Messi and Maradona, but discovered the PD-1 or PD-L1 and CTLA-4 mechanism of action. So this was the first shot to the moon after the anti-angiogenic drugs. So this is the rate response for most of the tumors with pembrolizumab, nivolumab, or ipilimumab. Most of them are near the 30% in rate response. So there are two Nobel Prizes for kidney cancer, 2018 and then 2019, with the development of the anti-CTLA-4 and anti-PD-1. And then we have the combinations with the angiogenesis and the immunotherapy. So this is all the 5 most important clinical trials that we have, with all were presented in the New England Journal of Medicine. Look at the rate response of the combination of lenvatinib for pembrolizumab. Look at 70% of rate response. That's a very nice number for physicians and obviously for patients. That's from 100 of patients, 70% of patients reduce tumors. So for us, it's a very nice number. So this is the new field in the chest, where the first line is with couples, ipi-nivo, cabozantinib and nivolumab, axitinib, pembrolizumab, lenvatinib plus pembrolizumab, and axitinib plus avelumab. That's the first line. And here we have the target. So look at, in a short period of time, how was the change of the treatments in renal cell cancer. We have to stratify according to the Henn criteria. And we have a patient, we have to decide with the patient and with the family all of these options. There is a room for active surveillance, there is a room for combination of immunotherapy, there is a role for combination immunotherapy plus target therapies and local treatment, surgery or radiation. So this is a success with a patient with a renal cancer with lung metastasis. Look at the tumor and in the left kidney, and the patient received immunotherapy. The patient had a very nice response, so it was really a success, but the toxicity is also a very important issue in Argentina, in Korea, and in the rest of the world. So what is our expectation about the treatment? Cure, to improve symptoms, to control the disease over the time, to reduce the number and the size of the lesions, to be low toxic and easy to receive and to continue, but costs, time, toxicity, and access are really very important issue from the clinician perspective also. So in a treatment you have the efficacy items, but you have the toxicity. We have to manage the toxicity, so the patients are the target to manage for the toxicity. Most of the toxicity are really very hard, caused by the tyrosine kinase inhibitor and the immunotherapy. They are really hard to manage. So we need the family, we need friends, we need groups, and we need the physicians and the nurse practitioners. Here in Latin America, we don't have nurse practitioners, so every patient have their own doctor. Thank you for the 3 minutes. So those are the adverse events that you have to manage. That is very important because we have to listen the voice of the patients. There are major discrepancies between toxicity that were reported by physicians and that toxicity report by patients. There are only 20% of concordance between toxicity report. That's a very short number. So we have to work more to understand better patients, and patients have to work more to understand physicians. We talk about lines of therapies. Yes, first line, second line, third line. Yes, that we can talk about lines, but I guess that we have to keep the patient in the right lines, in the right time, during the most of time. We have to hear the voice of patient, but you have to hear the voice of the science also. Look at the numbers in 1987. Just 20% of advanced patients are alive at a year. So it's a very short number. It's 1987. In 2022, we have 80% of patients that are alive at 1 year, and half of the patients are alive more than 5 years. So this is probably precision medicine, the right treatment for the right patient at the right time. That's, I guess, is a phrase. We have to work together. We have to work with a group of patients. It's very important to have all the governments, all the states, all the stakeholders looking for treatments. I guess barriers and opportunity. I have the last 2 minutes. There are the approvals in Argentina for first line. So we have sunitinib. We have Eric Jonas came here to Buenos Aires in 2010 for the 5 years of sunitinib. Look at the drugs that are available in the whole world. We have in Argentina, we have the approvals, but if you see all the system here in Argentina is very fragmented. The hyperfragmentation of the system is the huge problem. Look at the private practice is 14% of our population. The public system is 35% of patients. So that fragmentation is not only in Argentina. So you can see Argentina has very nice high cost drug flow for patients in private, but for hospitals is really very difficult. And for hospitals, look at, this was a resolution of last year, where the only drugs that are approved for kidney cancer for public health is nivolumab, pazopanib, and sunitinib. The others are not in the menu of the system, so that is one of the start point of VICARE, that is the group of kidney cancer. Look at Brazil. Brazil also is a fragmentation system, Costa Rica also, Panama also, Colombia also, Paraguay also. So every country have the complexity in the system that is very difficult to afford each drug in the right time for the right patient. So the reality is there are a lot of growing in the health spending money, so age probably more demands exist resources, so, and the resources are scarce, so we have to be more innovative. I guess the access to triangle to these drugs, data, price, demand, access, companies, group of patients. I believe that group of patients must be involved in approvals. That is the barriers, obviously lack of registry, lack of interest in corruption in our countries, inequities, drugs, radiation, education, technology in radiology, pathologies, techniques, molecular pathology, lack of clinical trials. That are all barriers to our region. So how can we try to jump these barriers? I guess we can work together. We have to improve the reference centers for the treatment for renal cancer. That are some tools that we can improve. There are modified variables. So education is modified. We can increase the education to population, to physicians, and to all the community, to healthcare providers. 1 minute, I know. So less than 1 minute. So multidisciplinary tumors are probably the best way to improve this room. So these are other points that is from Latin America. That are copies of pazopanib, the copies of axitinib, and the copies of levantinib. So that we can discuss guidelines, clinical trials. In Argentina and in the region, we have participated in a lot of clinical trials in renal cancer. So for us, clinical trials is an option. So our advances, yes, we have a lot of advances here in renal cancer. Vicare grows, that is the group Vivir con Cáncer de Riñón, is living with renal cancer here in Argentina, as was mentioned before, has only 2 years that was found, and it was related to the non-access to melanoma patient drugs. So I spoke with Claudia, who is the president of Vicare, because she had a friend that had in the public system, he can't afford the drug. So that is the map of the drugs in melanoma. So I guess this is the drugs in sarcomas. The red, we don't have the drugs, see, for sarcoma patients. So Vicare was born in this scenario, see, trying to bring the patient the adequate treatment in the adequate time. So this is living with kidney cancer. It's a very nice platform, has 2 years of life. There is a lot of programs, it's very interactive. So I guess for my perspective, the historical advance in the knowledge of the biology in renal cancer is amazing. The improvements in surgical techniques are really incredible. There are very effective medicines with historical efficacy in a resistant model tumor. But I guess that cooperation and multidisciplinary work is the only way to try to do better for patients. And in my final slide is not this, is the next. That thanks for coming to Argentina. I was the witness for the 3 cup. So here I have 9 years old, and now I have more than 5. But the last one in Qatar, this is the obelisk. If you have walking here, there were more or less 5 million people around the obelisk. So thank you very much for coming. And this year is the international meeting in Argentina. It's an international congress that's going to be to ASCO, ESMO, and I'm going to be the president. So thank you for coming.